Amina, could you please? Yeah, thank you. Okay. Good afternoon, everyone, and welcome to today's webinar. Today, we are going to talk about cervical cancer. We know cervical cancer is the leading cause of deaths among women with gynecological cancer in sub-Saharan Africa. So this is mainly a patient-centered webinar where we would like to educate the general public on the presentation of cervical cancer, its preventive strategies and symptoms and treatment, basically. So our speaker today is Dr. Mina Rashid. So Dr. Mina Rashid is a gynecologic oncology fellow at Moi University and based at Moi Teaching and Referral Hospital. She's also a fellow of the International Gynecological Cancer Society. She's currently the recipient of the National Institute of Health grant under the U54 mentorship program. Her areas of interest are cervical cancer and gestational trophoblastic neoplasia, on which she's currently doing some research. She's an active member of the Kenya Obstetrics and Gynecological Society and the International Gynecological Cancer Society. So I'd like to welcome Dr. Mina Rashid.
Thank you, Afrin, for the wonderful introduction. Today's really a very good day for all of us to be here, and the reason being that cervical cancer is a monster. It's killing our women, it's killing our sisters, our neighbors. You either have cervical cancer or you know somebody who has. And the funny or the interesting bit is it's 100% preventable. So why are we not preventing it? So let me share my slides and then I can take you through that journey of how we can prevent together cervical cancer. All right, thank you once again. Can you imagine that the 90 minutes that we are here together, seated, talking and listening to each other, the 90 minutes that we will be here together, 45 women will be dead by the end of this session. So WHO talks of 1 woman dying of cervical cancer every 2 minutes, and each one is a tragedy, and we can prevent it. Can you imagine that? 45 women by the end of this 90-minute session. That's a huge number. But then again, hey, it's something we can prevent. So why are we not preventing it? Why are we not doing everything we can to curb it and say no more cervical cancer? But all hope is not lost. For the first time ever, the world has come together and is committed more than ever to prevent cervical cancer. But let's look at the burden that's in the world and then compare it to what we have in Kenya. If you look at this chart that's drawn from GloboCan 2020, you can see that cervical cancer takes a small portion and it comes fourth after breast colorectal cancer and lung cancer. Unfortunately, GloboCan 2020 estimated that worldwide there are approximately 604,000 new cases of cervical cancer. And out of those 604,000 cases, you have, can you imagine, more than half of that die per year. And that's at 342,000 deaths annually. Unfortunately, what is even more baffling is more than 85% and more than 95% of these new cases and deaths that we witness, they occur in low and middle income countries, and that's where we fall. So now that we've seen the world, let's take a look at where we are at in Kenya. And again, this is GloboCan 2020. Look at cervix. Cervix comes second to breast, and this is everybody put together. That's both men and women. At 5,236, it comes second to breast. Again, if you look at just the women, it comes again second to breast. When you look at mortalities, it comes first. And our women are dying because of cervical cancer. But why? Let's look at this map. So this is the world map. And what you can see, so the incidence is higher in low and middle income countries. So generally all countries will be affected, but the incidence is higher in low and middle income countries. If you look at the areas that are dark red, and this is in Africa. So if you see Mali, you look at Nigeria down here, you look for Kenya on this side, Ethiopia, the only countries in Africa that are not as affected as we are the countries that are in the Northern Africa. But why? Look at our age standardized incidence rate that's at more than 26. All this that is dark red, the incidence is more than 26. That's the age standardized incidence rate. And it's highest in the higher risk countries, and that is in low and middle income countries. When you come to deaths or mortalities, we say nearly 90% of the 342,000 deaths that we talked about occur in low and middle income countries. And that's where we fall. Again, if you look at this world map and you look at Africa, and you start again with Mali, Nigeria, you come down all this side to Kenya and Ethiopia, you see it's really dark. And again, this tells you that our age standardized incidence rate, or the cases of the cases of deaths that we are having are more common again in Africa compared to the rest of the world. Let's listen to what Sally had to say. So Sally is a Kenyan, and she says in her own words, a series of events led to the loss of my husband and 2 children due to AIDS-related illness. Just when I thought I was done with the heart, and the pain, she says, I was diagnosed with stage 2 cervical cancer. This was the beginning of a long, rough, and many times uncertain journey. The sights and sounds of hospital rooms and corridors became commonplace. The agony of being stigmatized by those I thought I could depend on only added salt to my open wounds, she says. I had reached the end of my tether. As a victor, my experience revealed that indeed cervical cancer is curable, though I remain with lifetime scars. And she says, I have to walk around with a colostomy bag that collects my stool. Can you imagine that? And she says, I need 2 in a day, and each costs about 600 and 1,000 Kenyan shillings. That's a lot of money in a day. Early diagnosis, easy access to treatment facilities and support groups for the many people struggling with this disease can be a reality. She says, I'm an advocate for cancer, and my message to the world is no woman should die of cervical cancer. She says, let us join hands and eliminate it. Now you ask yourself, when you go to the gyne-oncology or the oncology wards in the hospitals, they're full of women with cervical cancer. When you have, say, 50 women admitted, 48 of them are like Sally. They all have advanced cervical cancer. Can you imagine that? And maybe you have 2 patients who have ovary or who have endometrium. But why is that? Why can we not have 1 or 2 patients who have cervical cancer and not the over 50 patients or the over 40 patients that you have in the ward? So we need to prevent this disease. But why do we need to prevent it again? We have, most of these women are young. I've seen 18-year-olds. I've seen about 3 18-year-olds with advanced cervical cancer. We have 20-year-olds, 30-year-olds, 40. These are women who are in their reproductive ages. These are women who want to have children, but they cannot because they have cervical cancer. And you cannot imagine the impact on their emotional and sexual health. It's really out of this world. Again, it's a preventable disease. It's curable if it's detected early, but you're not going to detect it unless you vaccinate yourself, unless you get yourself screened. Then you can get adequate treatment. Out of the 604,000 women that we talk of in terms of new cases in the world, this number is expected to rise to 700,000 between the year 2020 and the year 2030. And if you look at the deaths, that's at 342,000. Hey, this is expected again to rise to 400,000. That's such a high number. Again, what is even more, it makes you really feel sad, is more than 85% of these women, they are young, they are undereducated women, and they live in the world's poorest countries. Many of them are mothers of young children. Can you imagine an 18-year-old? Can you imagine a 20-year-old? Can you imagine a 30-year-old? These women have young children who are depending on them. So their survival is subsequently truncated by the premature deaths of these mothers. But why do we get cervical cancer? Do you ever ask yourself, why do people get cervical cancer? So traditionally, a long time ago, the most significant risk factors were thought to be associated with the risk of cervical cancer were the number of sexual partners to begin with, one, and then the early onset of sexual activity. But this observation led to the discovery that actually the primary cause of cervical cancer and pre-invasive disease was persistent infection with human papillomavirus. And hey, this is sexually transmitted. So what is HPV? HPV is a family of viruses. It infects your skin and your mucosa. There are about more than 150 types, but out of those 150, you have about 40 of them that will infect your genital tract. But not all of them cause cancer. Out of those 40, half of them will, we call them, they're non-cancer causing. They'll give you things like genital warts. And some of them are, we call them the human papillomavirus type 6. And then there's also 11, they're quite a number, but these are the common ones. But you look at the other side and you have the other half that we call high-risk HPV types or oncogenic HPV types. And the main culprits are HPV 16 and 18. They're quite a number, but just 16 and 18, can you imagine? They cause 70% of cervical cancer. But similarly, like I said, 6 and 11 would give you genital warts. But due to the early sexual debut that's there, or the early sexual activity, especially that's common in Africa, in Kenya, if you look at our sexual debut, the age is placed at around 13, 14 years. When you look at the more developed world, it's around 16, 17 years. Because of that, we end up having a peak of HPV infection in the second and the third decades of life. So these are women who are in their 20s, in their 30s, at 27% to 46%. But all is not lost. We say the median length of infection is about 8 to 12 months, and most individuals will clear the virus by 12 months. You get a HPV infection today, a year down the line, you've cleared the infection, luckily. At most women, over 80% will clear by 2 years. But however, there are some that are not so lucky. They're about 10 to 13% that may have chronic persistent HPV infection, and this can lead to genital warts, or it can lead to what we call cervical dysplasia, and this is pre-malignant cervical disease or invasive cervical cancer. Apart from HPV, we say human papillomavirus is not a sufficient risk factor alone. It cannot give you cervical cancer, or it cannot give you the pre-malignant disease that we talk of. So we say it's not sufficient, it's not enough, okay? But it's necessary. You must have HPV for you to get these infections or for you to get this disease. For you to be able now to develop that disease, you must have persistent HPV infection. And then this is related to what we call modifying factors. But what are these modifying factors? These are factors like, for example, you look at immunocompromised patients. So these are patients whose immunity is really low. Why? One, because they are on treatment that suppresses their immunity. They are organ transplant patients, or they have HIV. The WHO says that women living with HIV are 6 times more likely to develop cervical cancer compared to women who are HIV negative. How unfortunate is that? And then again, compared to women who are HIV negative, women who have HIV, apart from them being able to or be more predisposed to developing cervical cancer, they also develop it at a very young age. So these are way younger women compared to those that are or who are HIV negative. But then unfortunately, they're very unlucky, I should say, because unfortunately, cervical cancer among women living with HIV, it has not, and I repeat again, it has not received the attention, okay, the attention, the resources that are needed to address its prevention and treatment. But why? I think these are questions we need to ask our leaders, isn't it? So like I said, there are other risk factors. So apart from HIV, the other modifying factors are smoking. Are you a smoker? Please stop. Do you have multiple sexual partners? This will increase your risk of developing HPV and subsequently probably cervical cancer. Early sexual activity, like I said, the sexual debut or the early onset sexual activity in Kenya, it's put at around 13 to 14 years. Unprotected intercourse. And then we talk of other sexually transmitted infections. So all these put together, all these factors put together, what they do is they ease and they make it possible for the infection to happen, the HPV infection, and then subsequently end up with persistence. And eventually you end up with either a pre-malignant cervical disease or you have cervical cancer. Again, there are a number of ways you can prevent this disease. So how do we prevent this monster? It's a monster, isn't it? That's cervical cancer. There's primary prevention, there's secondary prevention, there's tertiary prevention. There's so many things you can do. So let's begin. When we talk of primary prevention, these are measures that you can put in place to prevent the disease before it occurs. And we look at it, how can we do this? And then after you've done your primary prevention, now you go to your secondary prevention. And this is a way to say, detect the disease very early before it causes more complications. And then you have the tertiary prevention. So this is where you already have, the disease has already occurred. So you want to mitigate, you want to control, prevent the complications that will come with the disease, right? There was a call to action by the WHO in May 2018. But what is it all about? So the director of WHO made a call to action for all countries, all of us put together. We need to come together to help end the suffering that's caused by cervical cancer. And he says, or rather he argues, for renewed political will, okay? Political will to realize elimination and urged all stakeholders, and that's all of us, isn't it, to unite behind this common goal. Let's all prevent cervical cancer. So what does this goal talk of? Or what does it say? So the global these are global efforts that aim at upholding health as a human right. Health is a human right, right? And as well as when you look at the 2030 Agenda for Sustainable Development Goals, they all point towards this 90-70-90. And what's the goal exactly? Leave no woman behind. Let's not leave any woman behind. Let's all move forward. So this call to action, what does it involve? So we talk of the 90, and then we talk of the 70 and the 90. So the 90 means, it's very simple. 90 means 90% of girls should be vaccinated by the age of 15 years. And this is a goal we are working towards. By the year 2030, we want to have an incidence or the number of cervical cancer cases that we get, we want to lower it to 4 per 100,000 per women years. Because look at it now, we are over 40, isn't it, per 100,000. So if we can get to less than 4, that would make a whole difference for our women, for our sisters, for our mothers. So that's 90% of girls vaccinated. Now I ask you in the public, have you vaccinated your girls? Have you vaccinated yourselves? Have you vaccinated your boys? Okay. If you have not, today, this is an opportunity for you to get vaccinated. Then we go to the 70%. So we say 70% of women are screened with a high performance test by the age of 35 years and again by 45 years of age. So again, I talk to you, the women, my sisters, the ones who are in the group. Are you screened? Have you had your screening done? When was your last screening? Do you know what is screening? Okay, So today, let's hope you'll be the ambassador for screening, and you're going to teach your neighbors and all the other women in your chama to go and have or to go and get them screened. Then we move to the other 90%. And remember, this is the call to action by WHO. What does it say? 90% of women identified with cervical disease receive treatment. And this is 90% of women with precancer disease and 90% of women with invasive disease managed. But how will we be able to treat 90% of these women? How will we pick these women with early disease? How will we pick these women who have precancer if we don't follow this 90-70, if we don't fulfill the first 90-70? It's not possible. So you must get vaccinated. You must get screened for you to be able to get the remaining or the last 90%. And achieving the 90-70-90 targets by 2030, this will result in over 62 million cervical cancer deaths averted by the year 2120. And you ask yourself, where will I be in 2120? Ask yourself, don't ask yourself that, ask yourself, where will the children of the world, the grandchildren, the great-grandchildren, where will they be by the year 2120? And you want to create an environment that is free of cervical cancer. So how do we prevent this monster? So we start with the primary prevention, right? Vaccinate, vaccinate, vaccinate. There are a number of vaccines that you can use to protect yourselves, your girls, your families, your loved ones. So we have a bivalent vaccine that's not in our market currently, but it was there before. It's good for you to know. The bivalent vaccine is used in some countries, like, for example, if you're in South Africa, the bivalent vaccine is used, it's a hospital-based vaccination program they have, and that's what they use to vaccinate their girls. It targets two types of HPV. Remember what I said, HPV 16 and 18 are the main culprits that cause more than 70% of cervical cancer. So it targets that, and it's called Cervix. Then we have the quadrivalent vaccine, Gardasil 4. All of you should know this because this is what is available at our clinics. Ours is still clinic-based. We hope in the future probably it will be school-based, for example. But this is what we have for now, Gardasil 4. It's clinic-based. It targets HPV 6, 11, 16, and 18. Remember we talked about this. HPV 6 and 11, we said they're non-oncogenic. They're the non-oncogenic types. They cause genital warts. And then you have 16 and 18 that cause the high-risk HPV and cause cervical cancer. And then lastly, you have a new kid in the block. You have the Gardasil 9, and this one targets 9 HPV types. So apart from the 2, 6, 11 that are low risk HPV types, it targets 7 high-risk HPV types. Unfortunately, it's not available at our clinics. It's not available at the public hospitals, but it's there at the private setups. So if you're able to get access to it, good enough. Who gets the vaccine? Who should we vaccinate? So the primary target group are young adolescent girls aged 9 to 14 years. And they're vaccinated free of charge as per the Kenya National guideline protocols. If you look up our national vaccination program, you'll find it. Then the WHO in 2022 recommended updating the dose schedules that you were using before for HPV as follows. So you give 1 to 2 dose schedules for the primary target. And the primary target were girls who are aged 9 to or who are aged 9 to 14 years. Then you have 1 to 2 dose schedules for young women who are aged 15 to 20. You move to 2 doses with a 6-month interval for women who are older than 21 years. Now you come to those women who are immunocompromised, and we talked about them. So these are including women who are infected with HIV, organ transplant women. They should receive 3 doses if feasible. If not, at least they should get 2 doses. There is limited evidence regarding the efficacy of a single dose in this group. These are the women who are immunocompromised. There is a group that's looking at single dose HPV vaccination among young African women. And it's been done already in Kenya, in Tanzania, and it's being led by our own Nelly Mugo. So what they're saying is over the 18-month time frame that they studied this single dose bivalent or the nonavalent HPV vaccine, they found that they were highly effective in preventing incident persistent oncogenic HPV infection. And this was similar to the multi-dose regimens. In our country, it's not yet endorsed, but WHO does recommend its use. Now, we've talked of how to mitigate HPV, and we said you can get vaccinated. But remember, we talked of all the other risk factors. So what can you do to prevent them? Let's start with avoidance of HPV exposure. Abstinence. It sounds a little bit difficult, but it's one of the ways to prevent. Then there's barrier contraceptive use. And you avoid all the other cofactors. So here we have smoking, safe sexual practices, and we need to educate our young men and women about the risk factors. There's also the use of media to pass information, and then we need to delay sexual exposure. Our girls are getting exposed at a pretty younger age compared to the more developed world. You've prevented yourself, you've done your vaccination. Now you need to move to secondary prevention. You're not stopping at the primary prevention. You've gotten vaccinated. So what do you do next? Let's move to secondary prevention. By achieving your secondary prevention, you'll be able to achieve the strategic actions that will eventually achieve 70% coverage for screening and 90% treatment of precancerous lesion. Remember, we talked about the 90, 70, 90. So here we are at the 70, 90, all right? So how do we do this? You need to get yourself screened, but you ask yourself, what is cervical cancer screening? So screening, these are tests that say, look for cancer in the cells in the cervix, and you ask yourself, where's the cervix? So if you look down here, so this is a uterus, okay? You're probably not familiar with how a uterus looks like, but this is how it usually looks like, okay? Down here at the bottom, you have, this is, say, the bottom of the uterus. That's what we would call it, okay? This is the cervix down here, okay? And then follow it here and on the side. If you can follow my cursor, this is the vagina, all right? So this is the cervix, okay? This is the area where you are likely to get either the pre-malignant or cervical cancer. So screening, when you screening tests, we look for cells that will turn into cancer or pre-cancer at this area down here, okay? And now you want to know, what tests can we use? What can I do to screen? There are different ways. So we have HPV, this is the human papillomavirus test, all right? And then secondly, on the left, you have the pap test, that's also called the pap smear. So all these are screening modalities. So when I talk of the pap smear, okay, this will involve taking cells from the surface of the cervix. Remember, we saw the cervix. So this takes cells from the surface of the cervix and they're sent to the lab, right? And then an expert, we call them pathologists, will look at the cells under a microscope, right? And I'm sure you've probably understood what I meant by HPV, okay? We talked of the HPV viruses, and this is a test that's able to pick if you have any HPV infection. We move down to visual inspection methods. And this, so we have VIA and then we have VILI. VIA means visual inspection with acetic acid. Acetic acid is just the table vinegar that we usually use at home. And then you have VILI, that's visual inspection with Lugol's iodine. And you use iodine to paint the cervix and look at it. So we'll quickly look at the recommendations in Kenya. But if you're not able to get the HPV test, then what is recommended is you get VIA or VILI together done, or one of them. And then the other option is if you can get a PAP. Women who are above 30 years, I'm going to talk about it briefly or shortly. they can have a HPV and a pap test combined. And that's why I put the combination test down here. So who should be screened? When should they be screened? Any woman who has ever had sexual intercourse is eligible for cervical cancer screening. This is for Kenya. So the target population for screening in women in Kenya is the age 25 to age 49. Other experts recommend, or in other countries, the recommendation is for them to get screened from the age of 21 to 65. Now, in Kenya, women who are aged 50 to 65, they're still at risk of cervical cancer. So what we say is they can still receive screening every 5 years, but this is dependent on individual resources. If you can afford, then well and good. So what are the screening methods that are advocated for in Kenya? So we talk of HPV testing, and this is the Kenyan screening program or guideline. So HPV testing is what is recommended as the primary screening method for women who are above 30 years. For women who are younger than 30 years, it becomes a little bit difficult because remember, most of them will have HPV infection. So when you do a HPV test for them, you're likely to get a false positive. So the recommendation is for women who are above 30 years. Now, where HPV testing is not available, or say this is for the healthcare workers, if you're thinking probably the patient who's seated with you, you're going to probably have a loss to follow up. She's not going to come back, okay? Then you can do a visual inspection with acetic acid or a visual inspection with combined with Lugol's iodine. And this is the recommended primary screening for that group. Now, when we talk of pap smear, who gets pap smear? So these are women who are not, say, eligible for, they're not eligible for VIA, they're not eligible for VIA-villi combined because you're not able to see the part of the cervix. Okay, and we talked of it, we said the bottom of the uterus, the part of the cervix that is meant to be screened, you're not able to see it for a number of reasons. The common one is women who are older, women who are postmenopausal, their cervix, okay, it shifts inwards. So you're not able to give them the appropriate screening in terms of doing a VIA-villi for them. So you do a pap smear for them. And then if you're not able to probably access a HPV screening, then you can offer the patient a pap smear if they can afford. Again, pap smear is also recommended for women who are under the age of 30 years, and it's also used as a co-test with HPV in women who are HIV infected, where, again, the resources allow. So you ask yourself, what should I do to prepare for a pap or a HPV? Are there any specific measures that you need to put in place for you to be able to be screened? Not really, okay? You do not need to do anything special. So sometimes some will tell you, you should not have sexual intercourse, you should not put anything in your vagina for 2 days before a pap. That's not necessary, okay? At times, so you can still have your pap, right? At times, you're expected to have a screening that day, and then you get your menses, and this is for the women. So what do? Do you miss your screening? No, you still go ahead. So screening can still be done, even if you're bleeding. Of course, it's wise to always talk to your doctor, because then they can advise you and tell you what to do, but you can still get screened. So we don't want you to miss your screening. And I want you all, and this is for the women, I want you all to look like this picture on the right, at the bottom, and not the one that's up here. Don't be afraid. It's not painful. It's very easy. You probably at most have a little bit of discomfort, but I want you to be all out there and say, hey, I'm going to go get screened. So what happens during your screening? Okay. And not just the pap, but also the HPV test. What should you expect? Okay. So for both tests, So I've put here down here, a self-collected sample can also be taken from the vagina by yourself. And there are kits that you can get from, if you're able to get a lab or a hospital that does HPV testing, if they can offer you a self-collecting sample, then you can go home, go to a private area and take the sample yourself. Okay, you don't need somebody to take it for you. So there's the one that the provider can do for you, and then there's the one that you can do by yourself. So what happens during a PAP or a HPV test? So for both HPV and PAP, your doctor will take cells from the surface of your cervix, as we said. They'll very gently, okay, and introduce a device called a speculum. So this is a speculum, if you can follow my cursor. They're not always metallic, so sometimes we do have some that are plastic and they're disposable. The only difference between the plastic and the metallic is that the plastic, the metallic one feels slightly cooler, let's say, when it's introduced. It's a bit cold compared to the plastic one, but we always tell you that, hey, you know what, you're going to feel a little cold, so don't worry. So they'll introduce this speculum into your vagina. And why do we do this? Why do we need to put something? Because the women always ask, when they see the speculum, they're always afraid and they say, hey, you know, what are you going to do? Why are you putting that? You know, the reason we put is because we want to be able to see your cervix very well. We cannot do that if we don't insert the speculum. It doesn't cause pain. There's just slight discomfort, like I said, and this is just to help push apart the vaginal walls so that, like I said, your doctor can see the cervix. It's small, okay? It's not very big, so don't worry. And then the doctor will introduce a small tool like what is here in between, all right? So sometimes you may have a different type of a brush, or you may have a spatula like this one, all right? But they're very small, they're very tiny, nothing to really worry about, ziko ndogo. So, so they'll take the cells from here, okay? You can see on the image from the cervix, and that's just, and it's very quick, it's just a few minutes, nothing to really worry about. Then you ask yourself, how often do I need to do this? Do I need to keep coming back every now and then? No, you don't need to do that. You only need to go once in a few years, for example. But all this depends on how are your old results, okay? If you've had a PAP done before, if you've done a visual inspection method before, if you've had an HPV test done before, how are the results? What did they show? And then you move to the other side and you ask yourself, are you immunocompromised? And this is not just patients who are HIV. We talked of patients who are on treatment, isn't it? Or organ transplant patients. So we generally talk of the age of 21 to 29 years for the initial screening. But in Kenya, the guidelines talk of 25 to 29 years. So if you're having a PAP, because that's the recommended screening for that age group, then you have the PAP every 3 years. Can you imagine? Every 3 years, you go only once to have that small uncomfortable test done. And it will save you a whole lot of agony afterwards. Then we look at the 30 or older women. And for these ones, a HPV test every 5 years. If it's possible and resources allow, then you can have a PAP test every 3 years, or you do a combination of a PAP and a HPV. And this is what we call a co-test every 5 years. So that's the ideal recommendation for women above 30 to have a co-test HPV combined with pap smear. But if you're not able to get that, then hey, you can still have a HPV alone, or you can still have a pap smear alone. And if that is still not available, you still have the visual inspection methods, and they're equally sensitive and specific. So don't worry, you're covered. Now you ask yourself, when do I stop? Do you continue screening for life? Are you going to do it until you're 100 years and above? So generally we stop screening by the age of 65, isn't it? And I'm sure quite a number of you know that. But this is dependent on a few things. Okay, we can't tell all our women who are 65, hey, you know what, stop screening. No, there are a few things you need to know. So one, have you been having your pap tests done regularly? Or have you been having your other screening modalities done regularly? Okay. And then you ask yourself, do you have 3 normal pap tests in a row? You've done 3 and all 3 are okay. Or you've had 2 normal combination pap plus HPV over the last 10 years. And of course, the most recent has to be within the last 5 years. Again, you ask yourself, do you have any medical condition that may weaken your immune system? Are you on any medication? Do you have HIV? Are you HIV infected, organ transplant patient? Then these are patients who are likely now to continue screening, either for life or more years. So not all women will stop screening at 65. All right. And then there are at times women may ask you, if I've had a hysterectomy, I've had my womb or my uterus removed, do I need to continue screening? Not all the time, but there are times you need to continue screening. So these are the questions you ask yourself. Was your cervix removed along with your uterus? And remember, we saw the cervix, the bottom of the uterus, okay? Was it removed along with your uterus? If it was not, and we call this a subtotal hysterectomy, then yes, you need to continue your screening. The other question you ask yourself, the hysterectomy that you had or your womb that's been removed, why was it removed? What was the reason? You always need to ask, if I'm having a surgery, why am I having that surgery? Okay, what's the need? So that you can understand your future risks. So do you have cervical cancer or have you had pre-cancer? And that's the reason your uterus was removed. If yes, then you need to continue screening. If at any time you're not sure, kindly talk to your doctor. You can talk to your nurse to help you figure out things, all right? There are women who will want to know, do I need to be screened if I have had the HPV vaccine? Yes. Okay, remember the HPV vaccine lowers your chances of getting a HPV infection that can lead to cervical cancer, but it does not completely protect you. So you should continue your screening. So you get the vaccination and then you continue the screening. If you've had an abnormal pap test or you've had an abnormal visual inspection method done and you have the result showing something abnormal, then what do? Don't worry. Many times the women panic and they say, oh, you know, I have an abnormal pap test. It's not synonymous to cancer. It does not mean when you have an abnormal test, you have cancer or you're going to get cancer. Most of this, most of the times, you need more tests to figure out what is causing this. And there are several things your doctor will look into, for example, or will consider, for example, your age. If you've had a pap done, how was your pap? If you've had a HPV done, okay? If you've had a VIA done, what was the result like? These are things that will guide your treating healthcare worker on what to do next. There are a number of follow-up tests that you can do. So what are they? We talked of the HPV test. So if you have an abnormal pap or you have an abnormal visual inspection method, then you can have a follow-up test like a HPV test done. At times, your healthcare giver may advise you that you need to have another pap in what? In 12 months. At times, you need to have a colposcopy. What is a colposcopy? Colposcopy is just an equipment or a device that is used to look into your cervix. You can see it has some light and it's magnified, all right? We use it to look at your cervix and see the tissue or the cervix better, okay? If you do have, unfortunately, if you do have pre-cancer, and which is not cancer, or unfortunately you have cervical cancer, there are quite a number of effective treatments that are available. And if found early, you can be cured, but you can never be found early, okay? You cannot get early diagnosis if you don't screen. So what am I saying? You need to get screened. Again, some of the women ask, if I've had a positive HPV, then what do I do? Now listen to this. Most people who have sex will be exposed to HPV at some point, all of us, okay? Having HPV does not mean that you will definitely get cancer. So when you do your HPV test and it's showing it's positive, it doesn't mean that you have or you're going to definitely get cancer. For most HPV infections, it goes away on its own. You clear. Okay, we said within 12 months. If it delays, at most within 2 years. Okay, if you have a long-lasting HPV infection, this is persistent HPV infection. So this now increases your risk of developing cervical cancer over time. All right. Now, if your HPV test comes back positive, all right, I'm back to the initial question. Now, your doctor or your nurse will talk to you and tell you or guide you on what to do next. Okay, we said having HPV is not synonymous to having cancer or you're going to get cancer. And how will they advise you? This will depend partly on whether your pap test results were abnormal, all right? If your HPV test is positive, but your pap test is normal, then you might need to repeat the test in 1 year so your doctor can see if anything has changed. We're still in the middle 70%. We want to prevent cervical cancer. To prevent, we need to be able to pick, which we've done the screening. You've picked a precancerous lesion. What do you do with it? How do you treat? What is it to begin with? So when we talk about precancerous lesion, this is, it just means that you have abnormal areas on your cervix, not cancer, it's pre-cancer, okay? And when we say treatment, we mean we're going to identify the abnormal cervical tissue, and then we will remove it. And when we remove, we don't remove the whole uterus, so don't worry. But why do we do this? We want to prevent worsening or spread to other areas of the cervix. There are two main types of treatment for cervical abnormalities. There are two ways of going about it. So one, we do treatments that remove the abnormal areas, and they're called excisional modalities or excisional therapy. There are a number of them. So healthcare workers in the group may be familiar with them. So there's conization. You can do loop electrosurgical excision procedure, LEEP. Okay, and then you have another modality. You have treatments that destroy. So we don't cut this one, we destroy. So we either expose your cervix to heat, okay, or cold. It destroys the abnormal area, and they're called ablative therapy. And each of these two modalities have prerequisites. They're the things we look at to decide, I'm going to do 1, 2, 3. Now, for you to get this treatment, do you need to go multiple times? Do you go once? It depends. So many times we have multiple visits. So what does this mean? That you go, you get screened, and then say, for example, an abnormality is picked, you get a biopsy done, and then you get treated. So those are multiple visits. And then you have a single visit. And this is also a way of treating our patients, our women. So what we do is we screen and we treat in the same sitting. I look at your cervix, okay? I do a visual inspection assessment, and I see a lesion. I offer you treatment based on what I have seen. This is a way of treating that's been recommended or endorsed by the World Health Organization. It's purely dependent on availability of resources, where you are, and your location. If you can access, you're not able to access a center to offer you the multiple visits, or you think you're not able to probably go back, or as healthcare workers in the group, if you have a woman who probably you think you may end up with a loss of contact, then you can offer this patient a see and treat depending on what you see. So the patient has to meet the criteria for offering them a see and treat approach. We've done our primary prevention, we've done our secondary prevention, okay? We're now on to tertiary prevention. So now what does this mean? Disease has happened. There's cervical cancer, but all is not lost. If you've done your vaccination, if you've had your screening done and everything is in order, I assure you, even if you were to get cervical cancer, it will be at a very, very early stage, okay? And you're cured 100% because you're offered treatment that is timely and appropriate. So when we get cervical cancer, how do the women present? How will you know you have cervical cancer? You will not know. If you have early disease, you have no symptoms at all. That's why we insist on screen, 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 and then vaccinate, vaccinate, vaccinate. However, unfortunately, if you have a little bit more advanced disease, then you may have irregular bleeding. And so this may come as spotting. These are spots, right? Or you may have light bleeding between the periods in, we say, women of reproductive age. The women who are postmenopausal, they may still have, they may also get bleeding. And you know what they tell you when they get bleeding? They say, I've become a girl again. But unfortunately, she has not become a girl. All right? She's still an older woman, but she has a disease. The other way that you can find out whether you have disease is you may have bleeding after sexual intercourse. And don't misunderstand, it doesn't mean that all women who have irregular bleeding or all women who have bleeding after sexual intercourse have cervical cancer. No. But if you see that, you need to be examined. So any abnormal vaginal bleeding need to be investigated. For the healthcare workers, if you have a patient, a young patient who is bleeding, like I said, I've seen a number of young patients, 18-year-olds, 20-year-olds, 30-year-olds, and they come with advanced disease and you feel really bad for them. Don't treat them. Don't put them on hormonal treatment. Don't treat them on treatment to stop the bleeding. Investigate, look at them, find out why is this patient bleeding. Now, as cervical cancer advances, you may have more severe symptoms, and this is really advanced, okay? You have persistent back, leg, or pelvic pain. And again, if you have that pain, it does not mean you have cervical cancer. It's that present with weight loss, you may have fatigue, loss of appetite, a foul-smelling discharge and vaginal discomfort, and then swelling of a leg or both lower legs, okay? You can have all this because of other causes, but if you have this, then it's time to get checked. Please get screened. How do we diagnose, right? So to begin with, we examine you. We do something called a biopsy, a small tissue where we saw the cervix was. We take a small, very, very small, tiny bite, and it's not painful again. It's just a little bit of discomfort, and we send that to the pathologist or a specialist who will look at that under the microscope and tell us, you know, this patient has cervical cancer or not. And then based on your stage, tumor size, we do what is called staging for you, and we give you stage. And this is done at the clinic. You don't need to go to theater. You don't need to, sometimes you may need to go to theater, but you don't 100% need to go to theater to be staged. But this will be at the discretion of your healthcare giver. So many times we do office or clinic staging. And of course, that's, we add a few other things. And this is based on the FIGO recommendations. So we'll do imaging. So we may do a CT scan or an MRI or even an ultrasound, depending on what is available, okay? Chest X-ray, and all this is geared towards finding you an appropriate stage and trying to find out how far has your disease gone. And then we treat you based on your stage. So you have a number of options. If we find you with early disease, say a stage 1, we're able to offer you surgery. And there are different ways of doing the surgery, depending on, again, the stage. There are also other modalities that we use apart from surgery, radiotherapy combined with chemotherapy. When you have really advanced disease or for whatever other reason, you're not able to get the surgery or you're not able to get the radiotherapy and chemotherapy, your healthcare giver will explain to you or your doctor will explain to you that you may need chemotherapy. And all of this will be done by your gynecological oncologist. We have quite a number of them in the country. So you need, if you have cervical cancer, you need to seek appropriate care from appropriate people. all right? And palliative care is also, let's not forget it, it's an essential element of cancer management, and this helps us to relieve or manage your unnecessary pain and also suffering that's due to the disease. So all this that we've said today, they will not make sense if we are not able to find strategies to eliminate this monster, that's cervical cancer, as a public health problem. But how do we do that? How do we get access to the vaccination? How do we get access to screening? How do we get timely treatment? We need political will. We need political support. And this is from our local leaders. You need to put your local leaders to task and tell them, hey, you know what? You need to support elimination of cervical cancer, all right? And there are many ways they can help you do that. We need cooperation among multi-sectoral patterns. We need support in terms of equitable access, universal health coverage. Most of the patients or most of the women, when they come to us, they don't have NHIF. And that's a basic need. It's the way you wake up and take water or take a cup of tea. You should all have your NHIF cover updated. You don't know when disease strikes. And that small cover does a lot for the patients who have cervical cancer. They're able to access most of the care that we offer them. Not all of it, but most of it, okay? Of course, we need resource mobilization. We talk of health system strengthening. And of course, we talk of, again, vigorous health promotion at all levels, okay? But all this, I say, starts with you and I. Now, in conclusion, cervical cancer is highly preventable. You can prevent 100%, but you need to get screened, you need to get vaccinated, okay? And screening uptake is the most important factor for a successful cervical cancer screening program. Preventive health goes hand in hand with screening. So let's be together. Let's leave no woman behind. Let's all move forward and prevent cervical cancer. Thank you.
Thank you, Amina. Could you please stop the slide share? Thank you, Dr. Amina, for that very wonderful and comprehensive presentation. I think you've covered almost everything. And yes, our key things or key messages in this presentation are mainly vaccination, and we need to vaccinate and we need to screen our women. So I see there are a number of questions. Let's look at the questions. Kindly type all your questions in the chat box and we will try to answer all of them. So the first question is, where are the vaccines available for the public?
Right. So like I said, Gardasil 4, that targets 4 HPV types, is available at basically all health facilities around you. So you can access that. The only concern would be it's meant for girls who are 9 to 14-year-olds. So if you have a young 9 to 14-year-old, you can take them there for screening. If you're able to afford Gardasil 9, then they're available at the private healthcare setups. So you can walk into any private healthcare setup near you and kindly inquire. But Gardasil 4 is available at our healthcare facilities.
Thank you. Let's look at the second question. Why is it now common to diagnose it in very young women, even under 20? And considering the pathogenesis of HPV to cervical cancer, why the trend? Why the change in the age trend?
All right. Okay. So like I said, when I talked of the risk factors, so one of the risk factors that I talked about is early sexual debut, right? The commencement of sexual activity is now at a younger age. And like I said, compared to the more developed world, which is at 17-year-old thereabout, in our country, it's at 13 to 14. And those are pretty much very young girls. hence probably the getting disease at an earlier age.
Thank you, Amina. So just to add on to that, yes, we are seeing cervical cancer in a relatively younger population than we were seeing previously. And this is because, like Dr. Amina said, there's an early initiation of sexual debut. And in as much as if you look at the old text, they say that it takes 10 to 15 years for a pre-malignant lesion, that means a precancerous lesion, to progress on to cancer. That is not the case, actually. There are quite a lot of other risk factors and a lot of interplay of these risk factors that causes or hastens the progression of these pre-malignant lesions. So once a woman is sexually active, she needs to be screened. And a recommendation is basically after 3 years of her sexual debut, these women should start their screening process. So let's look at the next question. Can an adult who has been sexually active with HPV test negative receive the vaccination?
So yes, it is dependent on the age of the adult you're talking of. So vaccination is recommended up to the age of 26 years. But again, now it is recommended up to the age of 45 years. So yes, they can still get vaccinated.
Okay, so the next question is from Elton Obaga. He asks, clients with HPV positive tests and a VIA positive test, is there a need to do HPV DNA serum? And I see some gynecologists advocating for these. However, I think he means in terms of cost, they're not very cost effective. Amina?
Sorry, what's the question again?
So he said that clients with HPV DNA positive and VIA positive, is then any need to do HPV DNA serum? And I see some gynecologists advocating for those. I believe what he means to say is HPV DNA testing is quite costly. So what's your comment on that regarding the cost of the HPV DNA testing? And after the patients have tested positive for HPV DNA, how do you proceed from there?
All right. So so when we have a positive HPV, it depends on what positivity you have. So if you've had, for example, genotyping done and you, for example, can tell that you have a low risk HPV type that's been picked on the HPV test that's been done, then probably nothing much, okay? But if you have, however, a high risk HPV type, then you may need to have a colposcopy done for you or for that patient.
Yes, so that's good. That's great. So yes, what Dr. Mina is saying, that once you have these an HPV test that is positive, and you have a VIA that is positive, this will basically warrant a further testing, or in some instances, we'll see. We talk about single visit approach, where we see the lesions and treat these lesions on the site. But this is again specific to certain settings and accessibility and availability of resources. So the next question is, why isn't HPV vaccine not available to boys of the same age group as girls in public hospitals or programs?
Okay, so now it's a little bit hard to answer that, because it all boils down to resources, right? So boys can still get vaccinated, but then they're not covered under the national vaccination program. It's just for the girls who are 9 to 14 years. However, we hope probably in the future that if we're able to get more resources pulled into the vaccination program, then probably then the boys must also get vaccinated. Yeah.
All right. So the next question is, in the setting of sexually active youths, what are your thoughts with the use of vaccine, yet there's likelihood of having a precancerous lesion?
Sorry, can you repeat that again?
So in the setting of sexually active youths, what are your thoughts with the use of vaccine, yet there's a likelihood of having precancerous lesions? So I believe what Salimotine is trying to say is a sexually active person who's had the precancerous lesion, can you vaccinate these women? And can you, they may have these lesions, but can you vaccinate these women after treatment of these lesions?
Yes, absolutely, yes. So again, it boils down to the age. How old is this woman? If she's between the ages of 9 to 45, yes, you still offer the vaccine. However, there's one thing you need to understand. The vaccines are for prophylaxis, they're for prevention, they're not for treatment. So it's not going to treat the infection that she has, but it's going to prevent her from the other HPV types, because remember, there are quite a number. So yes, they can get vaccinated depending on their age.
Okay, so I believe Dr. Mina answered this question in a presentation. When do you screen? When do you screen? And however, an additional question to this is, do you screen women during pregnancy?
All right, so when do you screen? And I want to assume that that's what that person means is the age. At what age do you start screening, right? So in Kenya, the recommendation is from the age of 25 to 49, all right? And the recommended screening modality is HPV. If that's not available, you can get a visual inspection assessment done. For women who are between the ages of 50 and 65, they can still get screened, all right? But that's dependent on availability of resources. Then how often you screen will depend on the modality of screening that has been used. Does that answer?
Yes, thank you. And the other, the next question is, how often do you screen women living with HIV? So I believe Dr. Mina answered this in a presentation, and the interval is these women need to be screened annually. So the next question is from an anonymous attendee, and the question is, can those girls who received Cervarix vaccine benefit from Gardasil 4 or Gardasil 9 to protect them from other types of viruses?
Okay, so say you've gotten the Cervarix vaccine and you've completed all the doses. No, you don't need to get the Gardasil 9 or the Gardasil 4. The Cervarix vaccine itself is gives you adequate prevention, right? However, if you've gotten, say, Cervarix and you've only gotten one dose, then you want to move to, say, Gardasil 4, Gardasil 9, you can still continue with the other vaccines. But if you've completed your vaccination with one, then you don't change, you don't restart with another. There's no point. And remember what I said about the single dose vaccination, that a single dose vaccination using Cervarix, using the bivalent, has equal prevention compared to the others. So yes.
Thank you. So the next question is, how often should one be vaccinated, especially those above 21 years of age and who are sexually active? The other question, just for the for awareness, do you need a booster dose of HPV vaccine?
So no, you don't need a booster dose of the HPV vaccine. So if you've received your vaccinations timely and you've completed the schedule, then no, you don't need a booster dose. It's not been shown to have any benefit.
Yes, and the other thing is, once you're vaccinated, it's a lifetime vaccine. You don't need it very frequently. Of course, there are different intervals during which you get your initial dose, the first dose and the second dose. But after that, you don't need any further vaccinations or boosters.
Absolutely.
So the next, So the next question is, why is cervical cancer being categorized as a non-communicable disease, yet it is caused by HPV infection virus?
Yes, go ahead, Afrin.
Okay, so just to answer that, so basically, cervical cancer is not spread through contact. The cancer itself is not spread through contact, though it is transmitted through a virus, which you can get through which is sexually transmitted. And however, you cannot get the cancer through direct contact. So that is why it's categorized as a non-communicable disease. It's not like flu. You know, with flu, you go next to a person who has flu and you're talking to the person via droplet infections, that is transmitted. But cervical cancer itself is not transmitted that way. Hence, the non-communicable disease. Hence, it's called a non-communicable disease. So, Amina, the next question is by Lucy, and she asks, kindly elaborate more about contraceptive barriers.
Yes. Now, Lucy, you've asked a little bit of a difficult question. All right. So when we talk of the barrier method, so you can use a condom to protect yourself. But the reason I say you've asked a difficult question is it does protect you. It's part of the preventive measure, but then there's still some contact. There's still some skin contact. So we say that despite, or sometimes because the particles are really small, they may still go through the condom. So we say, yes, you need to use a condom. You need to use a barrier method to prevent, but it doesn't mean that it will protect you 100%. That's why we put everything together and say, hey, you know, you need to do 1, 2, 3, 4, 5 things for you to be able to protect yourself. I don't know if that answers Afrin. Yeah, the condom is protecting,
I think you've,
but not 100%, you know, yeah.
Yes, definitely. It's not 100% because you can get HPV by skin-to-skin contact as well. So it's not 100% protective, but yes, it does offer some amount of protection. So now the next question is, this is a very interesting question. What are the symptoms of HPV and is there a treatment for HPV? Amina?
Yes, is there treatment for HPV?
Yeah, and what are the symptoms? We get HPV, women who are sexually active will get this infection. It's sexually transmitted. So are there any specific symptoms that we should look for? And is there a treatment for the same?
Yeah, okay. So one, there's no treatment for HPV per se, all right? So we say there's the vaccine, but it's preventive. It protects you before you get the infection, all right? And that's why we say girls should get vaccinated before they're sexually active or before sexual debut. There are no symptoms with regards to HPV. However, what you may have is if you have and again, don't get me wrong, HPV is not, having a HPV infection is not synonymous to having a pre-malignant lesion or disease or having cancer, right? It's just an infection. But when you have the HPV infection, especially if you have a high-risk HPV infection and you don't clear it, it persists, then you're at risk of developing cervical cancer or pre-invasive cervical disease. So then the symptoms that you may have is if you end up getting pre-malignant disease, then yes, you may, and I mean, even then you will not have symptoms, but if you end up getting invasive disease and it comes at an advanced stage, then yes, you'll have all the symptoms I talked about, the foul-smelling discharge, the bleeding, the pain, all right? But HPV itself, there are no symptoms.
Thank you, Amina. And just on the treatment, there is no treatment for HPV vaccine, HPV virus, actually. Most of 80% to 90% of the women clear this infection on their own. It takes a while. It can take anywhere between 6 to 2 years. However, if it persists beyond this period, then we call it persistent infection. And that is the virus that will actually go on to cause these abnormal changes in your cervix, actually, which will, if not treated, then have a chance or percentage of progressing onto cancer, to become cancer. So yes, it's very easy to prevent cervical cancer. The other question is now, what's the vaccine that is available in Kenya? I believe you answered this, but let's just answer this again. And what's the cost of these vaccines? The other question, just to follow up, for women who are older, where can they access these vaccines and at what cost?
All right. So again, a difficult question. So I want to pose it back to the person who is asking. and put you to task. I want you to put your local leader to task and say, hey, you know what, we need, because the vaccines are expiring in the clinics, and they are free. They're being thrown away after because nobody is using them. So when you go to the clinic at somebody who is older, say an 18-year-old or a 20-year-old, they'll not get the vaccine because it's meant for 9 to 14-year-olds, ideally. But here we are saying that you can vaccinate women up to 45, but why can't they access the vaccine? Because it's there. It's not like we lack the vaccine. That's why we need our local leaders to intervene, right? We need everybody to come together and say, you know what, we have the vaccine. Why are you not giving it to me? Because it's going to expire and you're going to throw it away. So so the vaccine is free for the 9 to 14-year-olds, and it's clinic-based, so you can walk to any healthcare facility near you and get your girls vaccinated. For those who are older than 14, unfortunately, as much as you are supposed to be able to access the vaccine, but then that's not the case. So if you can afford, then you can get it from a nearby health facility. So what you can get, the Gardasil 9 is quite expensive. It's more than 30,000, right? So it's very expensive. Gardasil 4 in the private setup, Afrin, how much would that cost?
I'm not sure, but I think it should cost anywhere between 15 to 30,000 or less.
Yeah, all right, okay. So yeah, so now we need to put our political leaders to task and say, these vaccines are recommended for up to the age of 45. Then why are you not vaccinating? Why are you not allowing these older girls and women get vaccinated? I hope that answers you.
Yes, thank you. Now just to add on a little bit to what Amina said. Yes, you can vaccinate older women. You can vaccinate women up to the age of 45. However, you need to note that vaccination at that age, after 26, is not really very effective. And what you need to do is, yes, in as much as you're vaccinating, now what you need to do is screening. You need to screen, and regular screening as per the recommendation in this age group, you know. And that's a very good preventive modality. And I'm emphasizing this because I think a lot of us have this question. So if I'm vaccinated at 45, is it okay? Do I need to go for screening? No, or at that age, after 26, kindly screening is more important than the vaccination. Vaccination is not very effective at that age. The other question is, are women who are menopausal still at a risk of getting cervical cancer?
Yes, they are. We do see quite a number of 70-year-olds, 60-year-olds. I've seen even 80-year-olds with cervical cancer. So yes, they are. Everybody is at risk. I mean, nobody is spared. And remember that from the time you get the infection, if you get infected by, say, you're 30 years old or even 20, sometimes it takes up to 30 years for the infection to show. So yes.
Okay, so the other question by Sylvester has been answered. Single visit not visible on screening. Yes, we do offer single visit approach, and yes, WHO has recommended it. However, this is usually, like I said, these are implemented in resources where which are very limited, and we know we may not get the women back. And yes, this approach is being used, and it's used also in Kenya, and it is quite effective. The other question is, does hormonal family planning method pose a risk to cervical cancer or other questions, other cancers? I think this is a very important question. Amina, do you want to take that?
So what's the question?
Does hormonal family planning methods pose a risk to cervical cancer or other cancers?
All right, so, wow, okay, a challenging question. I didn't put it in the risk factors because we also don't want to say that, hey, you know, you don't use contraceptives because they're going to predispose you to cervical cancer. So yes, it's been shown that oral contraceptives may predispose you to cervical cancer, but how? Listen to this. So say a woman somewhere is on oral contraceptives. Most of the women are worried of getting a pregnancy pregnancy. They're not really worried about sexually transmitted infections, HPV infection. So for most women and girls who are on oral contraceptives may not use barrier methods. They may not protect themselves. So that predisposes them in turn to acquiring the HPV infection. So yes, it does, but not directly. So yeah, unless Afrin, you want to add something to that.
Yes, thank you, Mina. So just to add on to, you see, if you're looking at the benefits versus the side effects of contraceptives, and contraceptives, yes, there is literature, but not very concrete literature that says that, yes, contraceptives are going to cause cervical cancer. And when I say contraceptives, in this case, I mean combined oral contraceptives, basically. This is the estrogen contraceptives with the combination of progesterone. So what basically these contraceptives would do is they cause a sort of eversion. They put the mouth of the cervix out, and so that becomes it's easier for the infection to get through. However, the other thing is, you see, this is like long-term for women who've used them for over 10 years, and the risk is very, very, very rare, you know. So again, there's not a lot of concrete literature that says that, yes, it is a causative or it's a risk factor that will increase. Yes, there is something, but nothing concrete. And if you're looking at the benefits of combined oral contraceptives or the other contraceptives, there are a lot. They're much more than the possible or probable adverse outcomes of the contraceptives. So the next question is, we just have time for another couple of more questions. So this is a good question. Can fibroids result to cancer, especially when painful and bleeding?
All right. So I'll take that question to mean probably in general other malignancies, because fibroids will not lead to cervical cancer. But however, some women may have a different disease or a different type of cancer that's called sarcoma, and the patients would probably have something that looks like a fibroid, not a fibroid per se, but these are women who are older many times, and these are fibroids. So these are tumors that grow very fast. So fibroids themselves are benign. They're not, I mean, they're not cancerous, okay? They're not malignant. But if you do have a fibroid, or you think you have a fibroid and you're bleeding, many times there may also be other issues that are associated with it. So kindly see a healthcare worker near you so that you can be assessed and examined.
Thank you. Amina, the next question is, what are the screening modalities in pregnant women, and when and how frequently do you need to screen these women?
All right. So pregnant women would ideally continue to get their routine screening, but however, the concern with women who are pregnant is when they're in the second trimester or third trimester, there are a number of changes that are on their cervix. So it may appear a bit abnormal to an untrained eye, or to an eye that's not used to seeing pregnant cervix. So yes, they can get screened. They get their routine normal screening. However, if as a healthcare worker or as a patient, you have an abnormality on your cervix and you're pregnant, then you probably need to be assessed further, and kindly probably see somebody who is a specialist in that area, because they're trained to look at a pregnant woman and look at their cervix and say, hey, you know, this is normal and this is abnormal, but yes, they can have their routine screening. The only thing they may not have probably is if there is a lesion, like I said, or if there is something that's been seen on your cervix, then you don't want it, you don't want somebody to do a biopsy for you anyhow. So then you seek care from a gynecologist near you so that they can assess your cervix and decide, does this warrant a biopsy, yes or no? But with regards to screening, yes, they can get screened.
Thank you, Amina. So in terms of screening, penetration in the community. What do you think about including pap smears to all postpartum mothers at 6 weeks in the postnatal clinics and even after following miscarriage? Any comments on that, Amina?
Right. So in general, you see, we need to screen all the women, regardless of whether they're postpartum 6 weeks or they're coming after miscarriage. The only catch is, like the person who's asking the question has said, is that you would do the screening. You would wait at least 6 weeks for probably the cervix to go back to its normal state, then you can offer the screening. But I always tell my people, please screen any woman who walks to the clinic, who walks to the hospital, screen everybody.
Thank you. So, Amina, are there any local studies on the outcomes of precancerous lesions and treatment outcomes, basically? So I believe
Yes.
Dr. Amina is currently doing a research on this, and which should be completed in the next year or so. So we will see the results on this, but however, we still have quite a number of publications which you can look. But yes, this is one of the first studies that Dr. Amina is doing. So we will have the results of this probably next year or the year after. So the other thing is, Amina, there's a lot of myths surrounding vaccination, and you'll hear a lot of people, even healthcare workers, saying that, oh, if I vaccinate my girl, she'll become more promiscuous, she's likely to get cancer, cervical cancer. So what do you have to say, or what are your comments regarding that?
A little bit challenging. You see, the vaccine is not meant to prevent promiscuity. It's just preventing an infection. All right. So I do understand that quite a number of people say that once you're vaccinated or your daughter is vaccinated, then it's like it opens doors for them to be promiscuous. But that's not the scenario, and it shouldn't be like that. All right. This is just preventing HPV infection. But how about all the other infections? How about HIV? How about all the other STIs? How about pregnancies? So when it comes to promiscuity, it really has nothing to do with the HPV vaccine. So it shouldn't make somebody be promiscuous after vaccination. Yeah, I don't know, Afrin, do you want to add something there? It sounds a little bit challenging.
I think you actually covered it all. So I think we'll take the last question now. So this is regarding oral cancer or esophageal cancers in women or men who have oral sex with infected persons with HIV. So how do you, is that possible? And do you have, are there any screening modalities for the same?
You froze a little bit there. Can you repeat what
Sorry,
you said?
so the last question is regarding oral or esophageal cancer in women or men who have oral sex in people infected with HPV. So is this possible, and are there any screening modalities for the same?
All right. So when we talk of, let me talk about the vaccination first, and then we can comment on the screening. So when we talk of vaccination, the vaccine is to protect HPV, regardless of the HPV type and regardless of what type of cancer it's going to cause. So HPV has been shown to cause oropharyngeal cancers as well, not just the group he's just talked about, but also for healthcare workers who are exposed probably almost on a daily basis to HPV infection in their clinics. So the vaccine does protect against HPV-related oropharyngeal cancers, right? That's one. Now, with regards to screening, I don't know about any screening modalities for the oropharynx. Probably I would need to refer to an ENT, but there are no screening modalities that I know of. Like, you're not going to swab and do a HPV test. Afrin, what do you think?
The vaccine you're absolutely right. Yeah, you're absolutely right. Yes, but the vaccines will prevent you from these cancers. Yes. Yeah. So with this, we come to the end of this presentation. Thank you so much, Dr. Amina, for this very comprehensive and wonderful presentation. Our take-home message from this presentation is prevention is key, actually. It's cheaper to prevent than to actually treat cervical cancer. And prevention modalities, the vaccines, the screening tests are available at your health centers, at the sub-county hospitals, the county hospitals. All you need to do is just get up and go there, make the effort, and you will be happy, actually. Thank you for being a wonderful audience and all your questions and joining in. And lastly, but not least, I'd like to thank the Kenyatta National Hospital team for organizing this webinar. Have a good day, and yeah, thank you.
Thank you very much for having us.